Welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy way. And this is our express revision course for oral and maxillofacial surgery. Before we get started, make sure you subscribe to the channel and hit on the bell icon so that you don't miss any of our exciting videos. You can also check out our website www.xtooth.com for the notes of this particular video and more interesting notes. And also you can check out the playlist for more interesting videos like this. So let's get started with the temporomandibular joint disorders today. And before we get started, let's revise the articular disc, because it is very important that we revise the articular disc. The temporomandibular joint anatomy we have already covered in the previous lecture. So this is the mandibular fossa, and the condyle of the mandibular fits in the mandibular fossa. And then we have the articular tubercle over here, and you can see the colored one is the articular disc. So this is the articular disc we have over here, the articular disc. So this disc comprises of three bands. We have the posterior band over here, which is in the purple color. This band is thicker as compared to the rest of the two bands, which is the intermediate and the anterior band, so which is somewhere around 3 millimeters. Then we have the intermediate band. So this is the intermediate band. Now the anterior most is our anterior band. So guys, this anterior band somewhere approximately is 2 millimeters. Intermediate band is the thinnest band, which is somewhere around 1 millimeters. And behind the articular disc, we also have the retrodiscal tissue. So here is the retrodiscal tissue, which is a vascular component. Now this articular disc is avascular. So whenever a person opens the mouth, what do we see, guys? First of all, let's see, there are two compartments which we have already covered in the previous part. So this is the upper compartment, upper joint space, and then we have the lower compartment, which is the lower joint space, right? So the upper compartment, as you can see, the shape of the upper compartment, if you have a look at this, this is somewhere like this. So that is the reason we can see this. The upper compartment is involved for the translatory motion. The lower compartment, if you see, is along with the condyle, so it is involved with a round. So as you can see, this condylar head is a kind of a round, so you can remember it, the lower compartment involved with the rotation movement. So once a person opens the mouth, say up to 20 millimeters, there is a rotatory movement which happens. So up to 20 millimeters, the first 20 millimeters of the mouth opening we say is involved with the rotation of the condyle, and beyond 20 millimeters up to 40 or 50 millimeters of the mouth opening, is somewhere around 3 to 4 fingers inside the mouth is the translatory action. So this is the normal positioning of the condyle at the mouth opening, right? So when a person opens the mouth, we see that the intermediate zone, it lies between the condyle and our mandibular fossa. This is when it happens at the normal mouth opening. But what do we see in case of temporomandibular joint disorders? We see that, say suppose this is the mandibular fossa, then we have the articular eminence over here, and this is the condyle. Now normally at the mouth opening, it is supposed to be the intermediate zone in between both of these, the mandibular fossa and the condyle. But what happens if there is a dislocation? In case of articular disc location, the articular disc is actually not at its normal position, it is located, it is dislocated, I must say. So articular disc is a biconcave shape, which we have already covered in the previous lecture, covering the normal anatomy. So what happens here, we see that the intermediate, instead of the intermediate zone coming in between the condyle and the glenoid fossa, we have the posterior band. And as we know that posterior to this posterior band is the retrodiscal tissue, and this retrodiscal tissue is vascular. And since this some part of the retrodiscal tissue also comes in between the glenoid fossa and the condyle, so because there is a pressure from the condyle, there is a pain associated with the temporomandibular joint disorders. There is a pain which we see in case of the disc displacement. So guys, there are two things which we will be covering in the today's lecture. One is the displacement of the disc, which is we call the disc displacement. So, disc displacement is nothing but the articular disc is displaced, right. So, articular disc, normally the intermediate zone of the articular disc comes in between the condyle and the glenoid fossa at the normal mouth opening, but what happens in case of a disc displacement, normally this displacement is in the anterior medial direction, and this displacement, the most common disc displacement is in the anterior medial direction. So, when the disc is displaced anteriorly, the posterior band and the retrodiscal tissue comes in contact between the glenoid fossa and the condyle, and this is the reason because the retrodiscal tissue is vascular. So, there is a pain associated with the temporomandibular joint disorders. Another thing which we will be covering in today's lecture is the Tmj dislocation. So, most of the time the students get confused between the disc displacement and the Tmj dislocation. So, disc displacement, as the name suggests, we will be talking about the displacement of the disc. But in case of Tmj dislocation, this condyle, instead of fitting into the glenoid fossa, it fits, say suppose this is the glenoid fossa, then we have the articular eminence over here. The condyle, instead of normally it sits in the glenoid fossa, instead of that it goes beyond the articular eminence. So, this is the dislocation of the condyle. So, in the Tmj dislocation, the condyle is the one which is not at its normal position, which has gone beyond the articular eminence. So, this is the posterior slope of the articular eminence. Normally what do we see is the posterior slope of the articular eminence is where the condyle is going to sit. But when it has gone beyond the posterior slope of the articular eminence, it gets locked at the anterior slope of the articular eminence, which is exactly this position, which is the anterior slope of the articular eminence, basically the preglenoid region, and this condyle cannot go back because it gets stuck in the articular eminence. So, this particular situation is the Tmj dislocation. Now, you know the differences between the displacement and the Tmj dislocation. This Tmj dislocation is, sometime we call it the subluxation also. We will be covering both of these terms in this lecture series, in this lecture itself. So, disc displacement is displacement of the disc, Tmj dislocation is when the condyle get displaced from its normal position. Then we have two more terminologies which student get confused is, say these are the maxillary teeth, right. Then we have the, here is the mandibular teeth. Now, what happens guys? One is deflection. Now, what happens when the patient opens the mouth? At the maximum mouth opening, the mandibular teeth or the mandible is getting deflected on the same side at the maximum mouth opening. So, this is deflection. So, basically deflection is not at the normal level. So, if normally is like this, then deflection will be like this. So, the mandible get deflected at the maximum mouth opening. So, this particular situation is known as the deflection. Deflection is when at the maximum mouth opening the mandible is deflected. The another term is deviation. Deviation is when the mandible is deviated on the one side, but at the maximum mouth opening we see that the mandible come back to its original position. So, deviation at, you see at the maximum mouth opening the mandible returns to the normal place. returns to the normal position. So, it is very important that we know the muscles of mastication, because muscles of mastication are very important when we are talking about the temporomandibular joint. So, when we open the mouth, we open the mandible. Once you open the mandible, the muscle which is involved is the lateral pterygoid. If you close the mouth, close the mandible, the muscles which are involved are the masseter, temporalis and the medial pterygoid. I have already covered the muscles of mastication in one of the lecture. You can check out in the playlist, you will find. So, these are the 4 muscles of mastication. Then there is also blood supply to the temporomandibular joint. So, you can remember it as MADS, M-A-D-S. So, which is the maxillary artery. Then we have the ascending pharyngeal. Then the D is deep auricular and S is the superficial temporal. So, MADs are the blood supply of the TMJ, maxillary, ascending pharyngeal, deep auricular and the superficial temporal artery. So, these muscles of mastication are involved with the temporomandibular joint, and we know that the condyle translates along the articular eminence. So, translation is when there is movement beyond 20 to 25 millimeters. Up to 20 to 25 there is rotation of the condyle, rotatory movement happens, and beyond that the condyle translates along the articular eminence. So, we will be covering the temporomandibular joint disorders in today's lecture. So, these are the disorders which are associated with abnormal temporomandibular joint functioning. So, based on the cause of the temporomandibular joint disorders by de Bont and his colleagues, we can classify as the non-articular and the articular. So, non-articular is the one which is not associated with the articular, not associated with the joint. So, that is going to be, you can say, the musculature, the muscles. So, muscles of mastication. So, if there is a dysfunction in the masticatory muscles, so that can include as a non-articular temporomandibular joint disorders, or you can also refer to them as the temporomandibular muscle disorders, because the muscles of mastication are involved in this. And if there is overuse of muscles of mastication, say suppose if the person is having a habit of bruxism, that means the clenching of the teeth. If you have seen some people clench their teeth, right, in stress or during the night times, so that can be associated with a masticatory muscle dysfunction or temporomandibular muscle disorder, or basically it comes in the category of non-articular, because we are not talking about the joints, we are talking about the surrounding muscles. So, the joint clenching. What happens if a person is clenching the teeth? So, we see that the most common disease which is associated is myofascial pain and dysfunction syndrome. So, which is our MPDS. So, that is myofascial pain and dysfunction syndrome, right. Now, in this case the person feels muscular pain. So, there is a diffuse pain around the ear, which is the diffuse preauricular pain, and tenderness also around the muscles of mastication, and also because the muscles of mastication are involved with the opening and the closing of the mandible. I have told you all the muscles of mastication are involved in the closing of the mandible except the lateral pterygoid, which is involved with the opening of the mandible. Since there is a dysfunction of the muscles of mastication, the person has been overusing the muscles of mastication due to bruxism habit or clenching habit. So, most commonly temporalis and the masseter muscle spasm is involved with the MPDs, but the person is going to have pain and tenderness over the preauricular region, and there is decreased mandibular movement because the muscles of mastication are involved with the mandibular movement. So, the mandible deviates to the affected site since this is a muscle involvement. So, in the radiograph you will not find any changes, you will find a normal radiograph. So, in this case what do we do? In case if a person is having myofascial pain and dysfunction syndrome, or basically a non-articular temporomandibular joint disorder, in this case you will have to check for the discrepancies, occlusal discrepancies. So, what we are going to do is we are going to do the adjustments, occlusal adjustments, and we give the night guard to the patient. So, basically we give a stabilizing appliance to stabilize. So, a stabilizing or stabilization appliance we can give. So, this appliance covers all the teeth of the one arch. This is to relax the muscles of mastication so that we protect the teeth from bruxism. If a person is doing bruxism or clenching the teeth, so we need to stabilize the TMJ, we need to redistribute the forces, we basically need to relax the muscles of mastication. How do we do that? We give a hard acrylic splint over the maxillary arch. We ask the patient to wear it for 24/7, but except during the meals time, patient can remove it, eat nicely and then clean it and place it back again. So, we give the night guard or the stabilization appliance in order to unload the forces on the joint or to reposition the joint in order to protect the occlusion. Also, we can give drugs like NSAIDs, muscle relaxants, analgesics, anti-inflammatory, anxiolytic. If a person is clenching the teeth in stress, then we can give the anxiolytic or antidepressants drug. So, we are just going to write analgesics. Then we can also give the anti-inflammatory, agents or anxiolytics, antidepressants, antihistamines, or we can also give the LA. Or we can also give the physical therapy to the patient. So, can be a stress reduction technique in order to reduce the stress. How we can give? We can also do the relaxation, biofeedback, acupuncture, acupressure, or the psychotherapy. Or we can give the physical therapies like TENS, transcutaneous electrical nerve stimulation, or iontophoresis. Iontophoresis is a technique in which we introduce some ions into the body. So, we introduced these medicinal compounds through the skin by applying some local electric current. We can also give some high volume stimulation, so that can like do the pumping effect of the muscle contraction to increase the circulation. Our main goal or motto is to remove the pain or the mandibular dysfunction. So, the most important thing is the diet. We want to reduce the forces of on the temporomandibular joint. We want to decrease the muscle activity. So, we ask the patient to have a liquid diet or a soft diet, not to eat very hard. We ask the patient not to eat hard, chewy foods. Basically, we ask the patient to cut food into very small pieces and not to have the chewing gums also, because that also induces pain. So, we are controlling the range of motion. That is about the non-articular temporomandibular joint disorders, which is involving the surrounding musculature. In that, we have covered the myofascial pain dysfunction syndrome. Then we have the another class, which is the articular. Articular, as the name suggests, it is involved with a joint. So, within the joint is the articular disorders. The most common among them is osteoarthritis and the osteoarthrosis. So, see guys, in case if the person is having early morning pain, that can be because of overnight the person has been doing the clenching habit or the bruxism. So, that can be involved with the muscles of mastication dysfunction. So, that can be due to the myofascial pain dysfunction syndrome, MPDS. In case a person is having pain at the end of the day, that can be due to the friction of the joints. So, that can be a reason due to osteoarthritis. So, an example in the articular can be osteoarthritis. I am going to write the differentiating feature. In MPDS, the person will have, if it is due to the bruxism or clenching, the person will have early morning pain. If the person is having pain at the end of the day, the reason can be due to the arthritis because of the friction of the joint. The joints get fatigued and the person feels pain at the end of the day. So, that is a degenerative joint disorders. So, in the articular TMDs, we see that there are degenerative joint disorders. That means the person joint are getting degenerated. The cause can be due to mechanical trauma or can be due to hypoxia. See what happens. Say suppose this is the blood vessel. So, in case if there is increase in the hydrostatic pressure in the capillaries, in the capsule I am sorry, if there is increase in the pressure outside, and what happens, there is increase in the blood vessel perfusion. So, blood comes out of the blood vessel, start accumulating in the joint capsule. So, there is less blood in the capillary. If there is less blood in the capillary, the person can have hypoxia. Hypoxia is basically decreased blood supply, right. So, that can be a cause for degenerative changes. So, the joint starts undergoing degeneration. So, that can also lead to osteoarthritis or osteoarthrosis, basically a degenerative joint disorder, or it can be the neurogenic inflammation of the joint. So, what happens, the person will have pain, clicking or popping sound. When the patient is chewing, eating food, the pain is with the function, when the person is having the functioning of the temporomandibular joint. And one more important thing is that I told you in the MPDS, there is no radiographic changes. But in case of degenerative changes, what happens, see there is, this is the condyle, right, this is the condylar head. What happens, it start undergoing erosion. It's when it is, there is a say suppose this is a joint. Now what happens, because of the friction of these joints, the joints start getting eroded. So, we see that this is a condylar head, and in the radiograph later on changes, there is flattening of this condylar head, which is noticed in the radiograph. So, the degenerative changes can be recorded in the radiograph, and what do we see is there is erosion. Initially there is erosion of the condyle head, and then later on there is flattening of the condylar head, which is usually unilateral in case of degenerative changes. Now, we have in the articular TMDs, the first one we will be talking about is the non-inflammatory arthropathies. In the non-inflammatory arthropathies, this is the most common one, which is the osteoarthrosis. Most common, let us just write it most common. So, it can be primary. The reason for primary we do not know, so that is idiopathic. It can be secondary. Secondary is usually due to any previous surgery or trauma. So, osteoarthrosis is again a degenerative joint disease. There is pain, clicking, popping sound, pain with the function. We see the radiographic changes associated, which is usually unilateral, or there can also be the bone and cartilage disorder also. Now, the another class in the articular TMDs we have is the inflammatory arthropathies. That means these are associated with the inflammation of the joint, and the most common we know is the rheumatoid arthritis, right. So, the most common we know is the rheumatoid arthritis. So, rheumatoid arthritis is usually bilateral, and this is how we differentiate between both of these, the osteoarthrosis and the rheumatoid arthritis. So, it is bilateral usually, and in the radiograph we see that there is erosion of the condylar head. So, this is the condylar head. The condylar head start eroding like this. So, what happens? The condyle becomes quite pointy like this. So, we see in the radiograph there is a pointed condyle due to erosion of the articulating surfaces. Also, in the inflammatory arthropathies, we have all the inflammation, which is synovitis, inflammation of the synovium, inflammation of the capsule is going to be capsulitis. So, capsule we have covered in the previous part, in which we have covered the temporomandibular joint anatomy. We also have ankylosing spondylitis, reactive arthritis, which is due to, can be due to bacteria or viral or any fungal infection, or we can have due to psoriasis is the psoriatic arthritis. Then the third one in the articular TMDs, the first one is the non-inflammatory arthropathies, in which we have covered the osteoarthrosis being the most common one. Then the inflammatory arthropathies we have covered rheumatoid arthritis and all these conditions. Then the growth disorder, that means the temporomandibular joint can be affected due to hyperplasia or hypoplasia. So, there can be hyperplasia of the condyle, or there can be hypoplasia of the condyle, or dysplasia in that matter, or there can be neoplastic disorders also. So, this is the classification which we have covered. In that we have covered the non-articular, which involves the surrounding musculature, surrounding muscles, the most common being the muscles of mastication. In that we have covered the temporomandibular, the myofascial pain and dysfunction syndrome, and we have also covered the articular one. So, the non-articular and the articular. Articular is when the joint is involved, when there is a disorder within the joint. The osteoarthritis, osteoarthrosis. Osteoarthrosis is the most common one. Now guys, I am going to show you, this is the temporomandibular joint, bilateral view. Here you can see the capsule. Let us just remove the capsule and see the articular disc. We will be covering, remove the capsule and see the articular disc. We will be covering the disc displacement and the subluxation in the today's part. So, you can see this articular disc, right, which is between the glenoid fossa and the condylar head. The condylar head is also colored. Now, you can see this articular disc which is surrounding whole of the condyle. So, the articular disc, there are three zones: the posterior band, the intermediate zone and the anterior band. At the mouth opening, see this is at the rest, at the mouth opening the intermediate zone is interpositioned between the condyle and the fossa. So, this particular situation is when the person is at rest. When the person is at rest, this is the situation, but when the person we see normally at the mouth opening, so we know this is the, we have the glenoid fossa. In the glenoid fossa, you will see the intermediate zone. Say suppose this is the intermediate zone, right, at the mouth opening. So, this is not a situation at mouth opening. I just want you to visualize like this. Say suppose this is at the mouth opening. Let us just draw all three zones. Say suppose this is the posterior band, then we have the intermediate band, and then we have the anterior band. So, intermediate is the thinnermost, right. So, say suppose this situation is at the normal mouth opening. When there is a displacement of the disc, that means this whole of the disc, is displaced anteriorly. So, instead of this situation, the situation becomes somewhat like this, somewhat like this. So, the posterior band comes here. In case of disc displacement, the posterior band will come here, then we will have the intermediate band and then the anterior band. So, the disc is displaced anteriorly and medially, you can see towards the midline. Normally disc displacement, that means whenever there is a disc displacement, most commonly we see the disc displacement in the anterior-medial direction. So, disc is normally displaced in this direction, not backwards, anteriorly. So, there is a retrodiscal tissue over here, there is a retrodiscal tissue and it gets pressed, because of that there is a pain. Now, there are two things. One is the disc displacement with reduction, another one is without reduction. In the trauma or fracture series also we have talked about the term reduction. Reduction means getting back to the normal state. So, if the person opens the mouth wide and the disc, the articular disc come back to its original position on its own, that is with reduction. So, let us cover both of these things. One is with reduction, another one is without reduction, right. With reduction means when the articular disc comes back to its normal state on its own. But when the disc is come back to its original position, there is a sound, tuck sound like that. So this sound is the clicking sound. So the person will have the clicking sound in case of the disc displacement with the reduction, and the muscle pain also. Without reduction is when the disc is not coming back to its original position. That means the mouth opening is compromised here. Since the disc is not coming back to its original position, we do not hear any clicking sound, but we see that there is a deviation of the mandible on the affected side. So there is going to be a deviation on this side, whichever is the affected side, whichever there is displacement of the disc, we see that deviation. And there is also decrease in the lateral excursive movement on the contralateral side. Now that you understand, the disc displacement is when the disc is displaced. When this articular disc, which is a disc is between the condyle and the glenoid fossa, as you have shown you in this animated diagram, animated video over here, that this disc is between the glenoid fossa and the condyle, and this disc is displaced anterior-medially. We see that there is anterior disc displacement. Guys, this disc displacement can be anterior or posterior, but the anterior disc displacement is the most common one which we see. And in the anterior disc displacement, there can be with reduction. That means the disc is going anteriorly but does not follow back to its, but it is following back to its original position. So that is with reduction. Without reduction is when it is not coming back to its original position, when the disc is locked. So there is a limited range of motion. So this is the disc displacement. Now let us talk about the Tmj dislocation. Now in the Tmj dislocation, normally what do we see is, this is the glenoid fossa and the condyle sits in the glenoid fossa. Now here is the articular eminence which we see. At the mouth opening, this is at the rest. At the mouth opening, what do we see is, the condyle translates and reaches up till here, which is the posterior slope of the articular eminence, right? This is the articular eminence. But what happens when this condyle is gone beyond the articular eminence and it get locked at the anterior slope of the articular eminence? Say the situation like this, when the condyle gets locked here, if it is not visible, let us draw it from another color. So when it get locked at the anterior slope of this articular eminence. So this situation is what do we call the Tmj dislocation. So we are not talking about the disc, we are talking about the condyle. If we are talking about the disc, the situation is what do we call the dislocation, but we are talking about the temporomandibular joint here, the condyle. So this situation is temporomandibular joint dislocation, right? So the condyle translates at the slope of, against the slope of the articular eminence. But what happens when it get locked beyond the articular slope, beyond the articular eminence, at the anterior slope of the articular eminence in the preglenoid region, and it cannot go back because this articular eminence protuberance, it cannot go back. So this situation is what do we call the Tmj dislocation. Normally we see that there is a forward and lateral movement of the upper joint. So there is a maximum the maximum movement of the upper joint in the translation is we see 1.5 centimeters. So this is the translation movement which occurs normally. But what happens when the translation is beyond the articular eminence and the condyle gets stuck here and cannot go back? So this situation is we call the Tmj dislocation. It can be unilateral, one side, it can be bilateral, both the joints are involved, and can be divided into acute. Acute is the one when it occurs at the first time, when the condyle gets stuck, get locked against the anterior slope of the articular eminence. Normally there is a posterior slope which is involved with the normal translatory movement, but what happens when it gets stuck or locked at the anterior slope? When it gets locked at the anterior slope of the articular eminence and it cannot go back, we call it the Tmj dislocation. So, when it occurs at the first time, we call it the acute. So, this is a self-limiting. It goes back again to its normal position. Say suppose after a long dental extended dental treatment, or after intubation, or for a prolonged mouth opening, say the person is yawning or singing, it gets stuck sometimes, or can be due to some drugs also, can be due to antipsychotic drugs or any connective tissue disorders like Ehlers-Danlos syndrome, we will be talking about in the subluxation, or can be due to trauma at the symphysis area, or it can be due to any muscular contraction, say muscle dystonia or anything like that. So, acute is when it occurs first time, it is self-limiting, but what if it keep on occurring again and again? So, then it becomes chronic. So, that is the Tmj dislocation is occurring again and again, multiple times, we call this chronic. And the third one is the subluxation. So, subluxation is the hypermobility of the temporomandibular joint when there is a chronic reoccurrence of the Tmj dislocation, when this condyle gets stuck here again and again, but it comes back. So, it is a self-reducing, it comes back, self-reducing, but it is chronic, self-reducing chronic reoccurrence of the Tmj dislocation. So, the patient gets back the condyle to its normal position on its own, but it is chronic, it is occurring multiple times, self-reducing. This situation or this subclassification of Tmj dislocation is what do we call the subluxation. The reason can be, say, if the capsule is weak or if there is trauma, the dislocation can occur. See, if the condyle gets stuck here and the patient cannot get back the condyle, so the person will be stuck in the mouth open situation. So, the person won't be open to close the mouth. See, when the person opens the mouth wide and the condyle gets stuck at the anterior slope of the articular eminence in the preglenoid region, the person won't be able to close the mouth again. So, there is going to be difficulty in speaking, there can be muscle spasm of the lateral pterygoid because the lateral pterygoid muscle is attached to the head of the condyle. So, also there can be deviation of the chin to the opposite side if unilateral Tmj dislocation is there. If the Tmj is dislocated at the one side, there can be deviation of the chin. If both the sides are involved, say suppose the person has opened the mouth wide and the condyle has stuck against the anterior slope, then the mouth will be like a kind of protruded mandible, right, because it has come out. So, in case of bilateral, we see the protruding chin or open bite. In case there is a Tmj dislocation of one side, then we see the deviation of the chin to the opposite side. The person definitely will have pain and won't be able to close the mouth. Most of the situation there is inability to open the mouth, but what if this condyle is stuck here at the articular eminence against the anterior slope, the person will open the mouth, will get stuck and won't be able to close it. So, what we need to do is, we need to reduce it manually. So, the person will come with the mouth wide open, but won't be able to close it. So, what you need to do is, you need to place your thumb inside the mouth on the molar teeth, both the hands, and then finger at the angle of the mandible, and we are going to do 3 movements. The first one is, let me just show you the situation so that you understand it better. Say suppose if the situation is like this, if the person's see, this is the situation, this is the articular eminence, right. So what happens, the other side I am showing you, what happens if it is stuck beyond the articular eminence? Normally the condyle slopes against the posterior slope of the articular eminence till here, but in case if it get dislocated, then what do you see? It has gone beyond the articular eminence and it cannot come back. So there are three movements which we are going to do is, you can remember it from Delhi Public School DPS. So the first one is the downward movement, then you need to do the forward, the posterior movement, and then the superior movement. So the condyle will come back here into the glenoid fossa. So downward movement, or you can say the inferior also, downward, then the posterior, and then the superior. So inferior or downward force you are going to put with the rotatory action. So with the rotation anteriorly and then posterior and superior movement. So the downward pressure on the posterior teeth, then the upward pressure on the chin, and then the posterior displacement of the mandible. You are going to take the mandible back to its original position, and then you have to do the functional restriction. Basically you need to stabilize the mouth so that the person is not opening the mouth wide in order to prevent the further dislocation. You can put the chin strap or you can lift the face with a bandage. Basically you need to immobilize it so that it does not occur again. You can also do the warm, ask the patient to do warm compression, give muscle relaxants, analgesics, and ask the person to be on a soft diet. So this is how do you reduce it when the person comes to you at the first occurrence. What if the person has not come to you and it has become chronic? So it has become multiple times. The very first thing you always do is go for a non-surgical method, which is the manual reduction, which we have done, which is this DPS, downward, posterior and superior. Then if it is chronic, you may have to go for the non-surgical, the surgical approach also. This is the non-surgical which we just talked about, the manual reduction. Then we have to go for the surgical also in case of chronic. In the surgical, what you can do is, you can decrease this translatory action. How you can do this? By formation of the fibrosis. You can initiate the fibrosis, you can produce some inflammation in the capsule area so that there is less translatory action. Or what you can do is, you can relax the muscle, the lateral pterygoid muscle. So you can give the botulinum toxin A injection. So that is an inhibitor of acetylcholine at the neuromuscular junction. So if you give this botulinum injection in the lateral pterygoid muscle, it will relax the muscle. Or you can do the arthroscopy, or what you can do is do the capsular plication. So basically removing some of the capsule, and then let me show you the part of the capsule. So this is the capsular part. So what you can do is remove some of the capsule and suture the remaining of the capsule. So basically you are tightening this capsule up. That also you can do, or you can do the myotomy, remove the muscle. So you can either remove the lateral pterygoid muscle, because lateral pterygoid pulls on opening the mouth, right. Lateral pterygoid is pulled because it is attached to the condylar head, or you can remove the temporalis also. Or what you can do is take the bone sutures and anchor the zygomatic arch to the condyle. That also you can do. Or you can remove, let me just again show you what we can also do is, we can remove this articular eminence. Now what happens in case of a disc displacement? The condyle comes here, right. What you can do is remove this articular eminence so that the condyle goes back to its original position again. So that procedure, removing the articular eminence, is what do we call eminectomy. Ectomy means to remove, right. Removing the eminence is eminectomy procedure. Or what you can do is remove this condylar head so that it does not get stuck here. So that is called high condylectomy. Or also you can remove this articular disc. So, that is our discectomy. That can also be done. There are other ways also. You can create this mechanical obstacle, like you are going to increase this length of the articular eminence. If we increase the length of this articular eminence, this condyle will only reach up to here against the posterior slope of the articular eminence. It will not go against the anterior slope. So, it will not pass the articular eminence. So, you can create the mechanical obstacle, you can put the titanium plates over here, or you can put the bone graft also, or mini plates. So, sometimes we do this procedure which is known as the Daughtery procedure. What is this Daughtery procedure? So, Daughtery procedure, that can be also asked as a question for MCQ or 2 marker, any question. So, what we do is, this is the zygomatic arch. We fracture the zygomatic arch and suspend it like this, so that this condyle head does not pass this articular eminence. So, we are displacing the zygomatic arch inferiorly. So, that is a Daughtery procedure. So, main goal is not to let go of the condyle. We do not want this condyle to pass the articular eminence, so that we are going to prevent the temporomandibular joint dislocation. Now that I think you understood the temporomandibular joint dislocation, you have understood the disc displacement and both of these terms. So, this displacement is the internal derangement of the disc. Disc is displaced usually in the anterior direction, it can be displaced anteriorly or posteriorly, but usually we see the anterior disc displacement, which is most common. So, it is displaced anterior-medially. So, we see that normally at the mouth opening, the intermediate band is between the condyle and the glenoid fossa, but at the mouth opening during the disc displacement, we see that the disc is displaced anteriorly. So, with reduction, without reduction, with reduction is when the disc displaced, but it comes back to its original position on its own. Without reduction is when it does not come back to its original position. So, that is without, when it does not. So, then we have there is one more also classification, the Wilkes classification, based on the severity or the chronicity of the disc displacement. So, that is stage 1 is early reducing disc displacement, stage 2 is late reducing disc displacement, 3 is non-reducing. So, can be acute or subacute. Then 4th one is again non-reducing, but it is chronic. Then the 5th one is also non-reducing, but it is chronic with the osteoarthritis. Then we have the Tmj dislocation or the subluxation. So, Tmj dislocation is when the condyle is dislocated. Now, normally what do we see? We see that the condyle translates against the slope of the articular eminence, basically the posterior slope of the articular eminence. So, the normal positioning of the condyle at rest is here, then it translates against the posterior slope of the articular eminence in the normal translation. So, there is a forward and lateral movement of the upper joint, and the maximum movement of the upper joint in the translation is 1.5 centimeters. Then in the Tmj dislocation, there is anterior slope of articular eminence, basically the pre-glenoid region, which translates with the condyle. So, the condyle has passed the articular eminence, gone beyond the articular eminence. Now, the condyle cannot come back to its original position. This situation can be unilateral and bilateral, which is the Tmj dislocation. It is further classified into acute, chronic and subluxation. So, in this case, the patient cannot close the mouth and there is difficulty in speaking. When the patient comes to you, what you need to do, reduce it manually. So, that is acute. When the occurrence is first time, can be due to prolonged mouth opening, yawning, singing, can be due to any drugs, intubation or trauma. So, the acute is, it's easy because it does not require any surgical management. We can just reduce it manually. So what we do, we place the thumb on the lower molars intraorally, and our fingers we place extraorally outside the mouth at the angle of the mandible. We push the mandible into downward direction, downward force with the rotation anteriorly, then posterior and superior movement. So first of all, there is downward pressure on the posterior teeth, then upward pressure on the chin and the posterior displacement of the mandible. Along with that, we have to restrict the movement of the person. How do we do it? How do we do it? By stabilizing, by immobilizing the mandible, giving chin straps and facelift bandages. We also ask the patient to do the warm compressions, also put the patient on muscle relaxants and analgesic. So that is the acute. Chronic one, when there is multiple reoccurrence. When the acute is progressed into the chronic one. Then subluxation is when there is a multiple occurrence, but it is again the self-reducing. The patient can get back the condyle to its normal position. So that is a subluxation. When the reduction can be done by the patient himself or herself, that is the self-reduction. When the condyle can get back to its original position, the patient doesn't have to come back to a dentist to reduce it manually. So that is the multiple reoccurrence, but it is self-reducing. That situation is what do we call the subluxation. So there is a hypermobility of the temporomandibular joint. The patient cannot close the mouth from the maximum mouth opening position. So when the patient has opened the mouth wide, say after yawning or extended period dental procedure, or most commonly the trauma or seizures. So in that case, the condyle get into subluxation. It is also associated with the Ehlers-Danlos syndrome and the Parkinson's disease. So this is Tmj dislocation, inability to close the mouth. The patient will have pain, difficulty in speech, and the surgical management. Now the surgical management, we have to reduce the translation so that the condyle doesn't go to the anterior slope. It stops at the posterior slope. So if we reduce the translation, we can reduce the movement. So how do we do it? Either we give the intra-joint injections of sclerosing agents, steroids or sodium tetradecyl sulfate, cyclophosphomides, or we can give 10% of dextrose. So basically we are limiting the motion, we are reducing the translation by inducing the fibrosis, by adhesions, by adhering. Also we can give the botulinum injection, which is basically a muscle relaxant, which is an inhibitor to acetylcholine. We can also induce contracture with the laser with the help of arthroscopy, and also we can cut the muscles. So we can reduce the forces, the muscle which is involved in the opening, which is the lateral pterygoid. So we can do the myotomy of the lateral pterygoid muscle or the temporalis muscle. Also we can remove some of the capsule and tighten the capsule, suture the rest of the capsule to tighten it. So that is a capsule plication, the capsular tightening surgery. Also we can remove the eminence, articular eminence, so that the condyle get back to its original position into the glenoid fossa. Again there is no restriction, so we can remove the restriction. So how can we achieve that? By either removing the eminence or removing the condyle head. So that way also the condyle head won't get stuck inside against the articular eminence. It can go back into the glenoid fossa. Also we can remove the intra-articular disc by doing the discotomy. Also guys, we can create the mechanical obstacle at the region of articular eminence. So we can either put some bone graft at the articular eminence, increasing the width of the articular eminence, or we can do the Daughtery procedure, wherein we use the zygomatic arch, we fracture it and displace it inferiorly so that the condyle doesn't pass the articular eminence. And in case of there is a long standing dislocation, we can also go for the orthognathic surgery. So this finishes the temporomandibular joint disorder. Next class, next video lecture, we will be covering Tmj ankylosis. Hope that you have enjoyed the video. You can check out the link in the description box below for the notes of this particular lecture. Also you can check out the website www.x2.com for the notes of this particular lecture. So guys, do comment in the comment section, and if you have enjoyed the video, give it a thumbs up. Keep reading, keep learning, stay motivated. I'll see you soon in the next lecture.